करना है मेरे को ये बताओ कभी कभी कुछ
वापस इसी पे जाते हैं
हाँ
इस टॉपिक पे में
ठीक है कभी कभी कुछ ग्लिच हो जाए बच्चों को डांट रहे हैं तो स्ट्रीमिंग में भी जा रहा है वो
नहीं ऐसा तो कोई दिक्कत नहीं है
अच्छा उससे कोई दिक्कत नहीं है चलिए ये लाइट चलिए प्लीज सेटल डाउन सो यू हैव एन एग्जाम when is it on 2nd okay. So today we'll discuss about primary healthcare. Now this particular topic is one of the most important topics in community medicine because this is one of the major pillars which after many years has been established as one of the most important pillar of community medicine, and unless and until you don't understand what is primary healthcare, you will not be able to understand, explore, grasp the concept that will be taught in the further classes. Now there are three broadly components of community medicine. You have epidemiology, you have primary healthcare, and ultimately you have statistics, which will help you relate the relationships that you have between primary healthcare and others. This thing. What are you seeing in your tab? क्या किताब खोल रखी है, क्या टैब खोल रखा है आपने? Notes. So you should not confuse primary healthcare with primary prevention. What is primary prevention? So primary prevention is one of the components or one of the major components of primary healthcare, but primary healthcare is not only primary prevention. Primary healthcare also includes secondary prevention, it also includes tertiary prevention, it also includes the components of each of these secondary and tertiary and primary prevention. So although the word is primary, one has to learn to distinguish between what is primary health, what is primary health care, and what is primary prevention. Okay. So we'll move on, and one of the famous sayings is the greatest medicine of all is teaching people how not to need it. You've been trained, we have been trained, I am a doctor, you yourselves are going to become doctors, but you do not want people to get sick so that your job is justified. You want that? So you want people to learn that how your job becomes less, how your skills that you have acquired are put to less use, and that can be done by teaching people how to not to need it. That is how what they should be doing, that they should not be needing these medicines, and that is why this component of preventive and primary care has come into this this curriculum that we have. And the other overarching principle which talks about equitable distribution, which is one of the pillars of this thing, is equity, and one of the pillars of primary healthcare, and that is summarized in this particular thought, that the idea that some lives matter less is the root of all that is wrong with the world. So you can philosophize about this particular topic, you can think about it, you can read about it, you can incorporate into what you read, what you understand of all the healthcare, of all the medicine that you learn, that there are two things that people should not, they should learn how not to need the medicine that they are needing to take, and secondly, every life matters. It is not only the riches, it is not only one particular country, it is not only one particular religion, every life that matters, and no life is less special or less worthy than any other this thing, and probably that is the problem that we see this thing. So it's a philosophical question, maybe a food for thought for all of you. So primary healthcare has two words, one is primary and the second one is healthcare. Now primary in this thing, it has over the years, the concept came way back in 1970s, where we have this, which will come in the next slide, the Alma-Ata Declaration. Alma-Ata is the name of a place, and it was in former USSR and now it is in Kazakhstan. So there a very big national conference was held, and there it was, this declaration of primary healthcare was given out, and since then it has become the basis of all public health that is practiced across the globe. It is not only in India, it is not only in Africa, it is across the globe, in the developed, in the developing, in the underdeveloped, every kind of country, primary healthcare has become the one of the major cornerstone of every healthcare system that is established. So, primary might mean first contact, that is your first primary caregiver, which is the first person you contact with when you become ill, or which is the first person you contact. It might be a healthcare provider, it might not be a healthcare provider. It could mean basic, and over the years it has been, some people have said that primary healthcare is poor quality healthcare. So, that is not the case. It does not mean that it is inadequate quality, it means that it is basic, and it is essential. It definitely does not mean that if you are not providing ICU care, if you are not providing big hospitals to a far off area and you are only providing primary health care, you are providing inadequate or poor quality care. That is what it does not imply. Okay. And secondly, it to increase the ambit of primary healthcare, it has also been included to include even essential surgeries, because when you read out the 4 pillars, you see that even some basic surgeries such as doing a cesarean section timely for a woman to prevent maternal mortality and to have a live born, that might be a component of primary healthcare. Okay. So, even essential surgeries, it is not that giving medications on OPD services. So, it is not about the kind of treatment that you are giving, it is the kind of logic and philosophy that you are employing to give that particular health service. That is what is primary healthcare. And if you look at it the broader perspective, we come again and again to the social determinants of health, that ultimately health is determined by nutrition, health is determined by behavior, and health is determined by education, by water, by sanitary services around the people that we are living around. So, when we talk about WASH, when we talk about these education services, then we have to think about the infectious disease model, and when we talk about behavior, we have to largely think about the cardiovascular disease or the other non-communicable disease, which are ultimately becoming a very, very important determinant of how health system is going to work. And healthcare, in primary healthcare, it is not only preventive, that is why I am telling you, you do have to distinguish it between primary prevention. Primary healthcare has components of primary, secondary as well as tertiary prevention, and that is why it has components of preventive as well as curative medical services. So, and curative medical services given in good quality. It is not that you have to give a curative health services by a high dependency unit in an ICU or by building these hospitals or by providing MRI machines. That is only not good quality. Quality can be basic services which are provided in the best, at the right time and at the right place and to the right person. Even providing a simple ORS to a child who is having diarrhea, provided at the time that to prevent dehydration, might be the right most appropriate technology that might prevent that the death of that particular baby. Then we have been trained, I have been trained, and even up till now we have this biomedical model of disease orientation where patients are only thought of as passive recipient. You are sick, you come to us, we will write you a prescription, we prescribe things to people. We do not expect them to understand for themselves that how they should not need this prescription. We do not expect people to understand that they should do something so that they do not come to us for a prescription. So, that is a biomedical, a hierarchical nature of biomedical this thing, that the patient is the taker and a doctor is the giver. But over the many years, if you, when you become as practitioners of medicine and when you read more literature about, how the medicine field are involved, you will realize that we are trying to move away from this biomedical concept. We want people to take health in their own hands, and obviously that is the only solution. You cannot, keep providing curative care and, allow people to get sick. You have to expect people, you have to teach people to take accountability of their own health. Okay, and that is why this biomedical sciences of you becoming the giver and the patient simply being a recipient of the prescription that you are prescribing it has to erode, and it is in a good way, that you are treating only when something cannot be prevented, then you treat it. But to expect people that they can get sick so that you are going to treat them is not something, and that hierarchical nature of we are above the people or we are no more than you, that also has to be removed from the orientation of medical doctors. And so, you have to create environments which are health promoting. You cannot want people to keep getting sick, living in environments where you have air pollution, living in environments where you have water pollution, so that they get sick and then they come to us and we only go about treating. So, preventive care is obviously the answer to most of the problems that is there. It is not an easy answer, that is the problem. Health as a social phenomenon whose determinants cannot be neatly separated from other social and economic determinants. I think it has been discussed with you over the many classes, at least I have taken, that how social and economic determinants are going to determine the health outcomes, and so ultimately the social, community and behavioral determinants of health. So, the Almada Declaration came about in 1978. You need to know the name of this declaration, probably the year if you can remember. If 1980, if you remember, that is also good enough for us. It was held in Kazakhstan, then USSR, on the date of 6 to 12 September in 1978, organized by WHO and the UNICEF. It emphasized that health is a fundamental human right. Now, right up till 1970, in the 1960s, the health that was delivered to people was only delivered as a part of that biomedical science, that people are getting sick, and the focus was mostly on building more and more hospitals, so that more and more hospitals can cater to more and more patients that are getting sick. But that cannot be the end of all the people that are getting sick. So, it was saying that health is a fundamental human right, and you cannot deprive a certain section, you cannot deprive a large proportion of the population, that you allow them to get sick and then come to us for getting treated. Inequality in health status between developed and developing countries is unacceptable. However, it was the truth at that time, and it is still a very glaring or an unacceptable truth, that, but at that time it was realized that hospitals are not the solution, and building more and more hospitals, big and small, providing care in the hospitals were not the solution to all the problems that we are having at that point in times. Please stop talking. And that is why primary health care was the key to achieving health for all by the year 2000. That was one of the determinants that was put up, that this is the declaration that we are going to take. It is a 3-page declaration. I will share in the group if you want to. You can go through it, you might understand some words, you might not understand some words, but happening about 40 years ago, that was something that was really life changing. Now we talk about primary health care every day. All the health policies are evolving across the globe. In India, which is developed, evolving only around primary health care. But at that time, it was a very new idea that talking people of going to the community or going to a place where you are the doctor getting outside the hospital and giving some kind of services or education was something which was not really heard of at that point in time. So, the core principles are 5: equitable distribution, community participation, intersectoral coordination, appropriate technology, and focus on preventive and curative services. Now, there are two things in primary health care, that is what are the principles and what are the components. So, I will be talking about the principles today, and the components will be taught to you in the next class. So, these principles is something that you should be knowing about, and you should, if anybody simply asks about what are the principles of primary health care, you should be able to list out these 5 components, and this is something that you should remember. So, now we will go ahead taking each of these components and how with examples you will try to understand and what is equitable distribution, what is community participation, and when we have applied these principles of primary healthcare, how do we know that it is effective in decreasing in saving lives? So, you have to have evidence. So, it is not that something has come up, everybody decided okay, it is a good thing that we should be providing preventive healthcare and we should stop building hospitals and let us just do it. It is definitely based on a lot of research, and a lot of research is still being done, that incorporating these principles in the healthcare that is delivered, whether that actually saves lives, whether that actually helps people not fall sick. So, you have to have evidence, and that is done by epidemiological studies. So, when you read in your 3rd and 4th semester about epidemiology, then only you will understand you will be able to understand that it's a cause and effect relationship also, that you give this primary health care and less people die, you give primary health care, less people fall sick. So, there is scientific evidence with regards to this. Okay, it is not something that it's a hunch or it's a policy or it's a philosophy that has been put into the health system and everybody is just going along with it, because it is probably cheap, it is cost effective. That is one of the reasons of primary health care, but that is not the reason why it is being pushed as an agenda for healthcare. It is being accepted as an agenda for healthcare because it actually saves lives at a minimal cost rather than building hospitals everywhere. Okay. So when we were doing our undergraduation, we were expected to learn this definition. I don't know how many subjects are expected to you to learn definition. Do you learn definitions anymore? Because everything is now available, you know, at the click of a mouse or in your mobile phone. So did it in your 12th standard? Did you learn definitions? You know, mug up, इस चीज की definition बताओ. It still happens. So community medicine, if you want to learn any definition, please learn this. We have learned this definition. These words scientifically sound. That was the first Viva question that we were asked. What is primary health care? So if you learn this definition, even if you mug it up, whatever answers you give with respect to community medicine, ultimately they are going to be based on this definition. Okay, so the entire the philosophy of community medicine as of today is largely based on primary health care. So this definition is, it's an essential health care based on practical, scientifically sound, socially acceptable methods and technology made universally accessible to individuals and families in the community through their full participation and at a cost that the community and the country can afford to maintain at every stage of their development in the spirit of self-reliance and self-determination. I think the PGs should mug it up. Okay, it will give a very good impression in your exam that you should know. And UGs, because you are younger, I expect that it is easier for you to learn up. But if you read this definition and those 5 components, I think that is good enough if you take away these from this particular class, that what is the definition of primary health care and what are the 5 principles of primary health care. Fine. So this definition is obviously incorporated in the principles that we have had, and those principles are incorporated in this definition. So you should know about that. The important points have been highlighted. We'll go through it further. So what are the principles and what are the components? Principles I've already talked to you about, and what are the components of primary health care would be health education, nutrition, safe water and sanitation, maternal and child health care, immunization, disease control, essential drugs and basic treatment. It is not ending at that. When you read at the next class, you will realize that it is, these are the more components. When you talk about principle, this is the overall philosophy for which primary health care is based upon. Now, what is equitable distribution in primary health care principle? In Jamkhed, way back in 1980s, that's a place in Maharashtra. And the other example is the China Barefoot Doctors Program. Now, this China Barefoot Doctors Program that worked very in precedence of this Jamkhed program. So I have every slide I have put in 2 examples, one from India and one from the outside of India. So when we talk about equitable distribution, is people should be getting according to what they need. That is what we are talking about. That people, if a person is living in a rural area and he does not have access to any healthcare services, it is the equitable distribution would mean that that person should also get access to an healthcare services. That is what is equitable means. Everybody gets according to what they need and everybody gets what they need. So this particular program of comprehensive rural health program in Jamkhed, the PGs should read it in detail. There is an entire book of how, and this is one of the interventions that was done in this place, and it is still being used as a case study across the globe. All courses in public health, all courses in community health, all courses in global health, anywhere you need, this is given as a very important example, because that was one of the pioneering works of primary healthcare that was done in India, and it was done by 2 people, that is Raj Arole and Mabel Arole in 1970s. The objective was to bring low cost community driven primary healthcare to rural and urban underserved communities. Now, because it was underserved communities, that is why you talk about equitable distribution. So these communities who were not able to access health facilities because of maybe distance, because of other community factors, or maybe because of other social factors, people from these particular communities were taken up. They were trained to give very simple interventions. Very simple interventions means very simple. That is, you give ORS at the time you detect dehydration. You do not have to come to a hospital to detect dehydration in from diarrhea, and you do not have to come to the hospital to get a packet of ORS, because most of the diarrheas do not need any other treatment apart from ORS and zinc. And you will be surprised, and we are very shocked when we see students coming as interns, when you are not able to prescribe diarrhea, ORS for a case of diarrhea in under 5, and not able to assess dehydration for a case of under 5. People who are minimally educated were trained in this particular program to detect diarrhea, that a mother is coming that okay, this child has diarrhea, to detect dehydration, you make a diagnosis, a very provisional diagnosis of dehydration, and if dehydration is there, that community health worker was only supposed to give ORS. And ORS has actually saved more lives than any other antibiotic, than any other high end technology that might have been there. So when you talk about saving lives of children, ORS is one of the most, what should I say, a threshold or a life changing intervention for child health care. ORS, zinc and immunization. Okay. So, the training of village health workers, local women provided maternal care, treatment and education, mobile health team support, wherein equitable is the far off places were given these mobile health support, that is, since the patients were not able to come to the hospital, a mobile van with one of the basic facilities, because what we see as basic right now was not very basic at that point in time. So, what we are seeing, day in and day out, that we go to a urban health center, we go to a primary health center, we go to our rural health centers, that had only come about after these particular primary health care principles had come into the system of health. And the community empowerment, that is simple education about hand washing. Simple education about that you are supposed to wash your hands after after attending to a child, or you have to wash your hands after cooking food. Even these simple things were were taught to people, which was not a part of the the orientation of medical sciences at that point in time. At that point, the orientation of medical sciences was largely about, even if we knew that hand washing causes disease, even if we knew that not breastfeeding a baby is going to make that child sick, that was not stressed upon enough, so that babies continue to die and women continue to feed their children with dirty hands and they falling sick. And then use of simple appropriate technology such as growth charts, ORS or clean delivery kits and more. It will come across when we read about community medicine, that these principles of primary healthcare are incorporated in any intervention that has that our country has. And ultimately, it was seen that the infant mortality, that is number of children less than 1 year of age who were dying because of many of the causes, it actually decreased from 176 to under 20 per thousand in the project area. So, that is the evidence that this primary healthcare generated, that even you need not have a doctor to help people stop babies from dying. Some of them are ultimately anyways might die because of not having doctors at the right time at the right tables. You can still save a lot of them by not having a doctor, but a trained professional who can tell them about the basic things, and then that might prevent a baby from dying. So, it actually brought down the neonatal infant mortality rate in that particular area from 176 to about 20 per thousand live births, and that is why it is being talked about as it's a case study which is studied across the globe, and it is India is one of the examples where it is given. The other example is the China Barefoot Doctors Program, where we had trained community members to deliver basic care in rural areas. So, if you have a cut, they were used to maybe give a tetanus vaccination. If you had a cut, they were trained to clean the wound and maybe provide some antibiotic or any kind of bandage over that particular this thing. So, people were not expected to come to the hospitals, and these barefoot doctors, these were local farmers only. They were not very even qualified people who maybe need to were graduates. They were only farmers who were received short term training about 3 to 6 months in basic medicine, hygiene, sanitation, family planning and disease prevention, and they were called barefoot because they worked in the field like farmers and practiced medicine part time. And that is from where this was the initial basis of from where primary healthcare, that people have to go to the community to prevent people from dying. That was the concept of primary healthcare has brought out, that you have to go to the community. You should not be sitting in hospitals and expect people to come to you to prevent them from dying. You have to go to the community, understand that what is causing them to die, and the concept of surveillance, where what people were dying from, because when the idea was that you have the doctors largely stayed in the hospital and there was no healthcare that was provided in the community, we never knew what was happening in the community. So this barefoot doctors, they used to go house to house, because at that time it was not that you had mobile phones or you had apps. They used to go house to house and make a record of all the deaths that have occurred over the in that particular 6 months, and then that record was analyzed, or it was understood that okay, these are the things that are making people die. So that was the most basic form of surveillance that was practiced in the 1970s, and that brought about that you have to go to the community to understand what is happening, and ultimately that is going to prevent deaths rather than just building new hospitals. So the equitable distribution component is because it reached about 90%, which was at that point in time China was largely rural, and these particular people were trained only to serve to that rural population, and so it reached to the large proportion of that population. So it bridged the gap between healthcare access between urban and rural population. The second component is community participation. Another example, Gadchiroli, again you should read about. Jamkhed and Gadchiroli is it's basic teaching for postgraduates. Although if you might be interested, this Gadchiroli also organizes some undergraduates programs, for orientation. If you can visit, they have these 1 or 2 week internships. So if anybody would be interested, you can go to their website. Even I have thought about it, but I could never reach there. But some of our PGs have been there. So they do it for undergraduates during a vacation. You might want to visit and understand that how these things work if you might be interested. So both Gadchiroli and Jamkhed, they have these internships, they have the observerships, which might be of they might be eye openers for you. That is what I can say. So in this HBNC, it is one of the cornerstone of preventing neonatal deaths in our country, and it was way back in 1970s when this program was first implemented, and then ultimately it is one of the interventions that is done across India. It is scientific based, that home based newborn care has to be given to all individuals, to all babies that are born. It is not an option that is there that all babies are born in the hospital, they go back to their houses and nobody knows about that. It does not happen anymore. All babies that are born, a trained health worker is supposed to visit these babies up till the first 42 days of life at regular intervals, note what are the complications, what are the weight of the child, and there is a checklist of home based newborn care, and ultimately that will help determine that this baby survives that neonatal period. Because I think I have discussed with you that of all the deaths that occur in the first year, that occurs in the first month of life, and all the deaths that occur in the first month of life, that occurs in the first week, and out of the first week that occurs in the first 48 hours, and out of most, that is 50%, most of them occurs in the first 24 hours. So these visits are clustered around the earlier period. It is 0, 3, 7, 14, 28 and 42. So the initial is within the 3 days at least 3 visits should happen for that particular baby, and further on at the 15th day, at the 1 week, and then ultimately at the 42 days. So what happened was, this was developed in Gadchiroli, Maharashtra, and these both of them, they were doctors, Dr. Abe Bhang and Rani Bhang, and that was in the 1990s, where local women again were trained as village health workers to provide essential newborn care. Obviously, one component of equitable distribution is not separate from community participation. You obviously have each of these components in each of the examples, but these have been given to highlight that particular component or that particular principle that I am talking about. So local women trained as health workers to provide essential newborn care. They conducted home visits for the first 48 days. They engaged in community and planning and decision making, raised awareness through mothers groups and health meetings, and this also reduced the neonatal mortality of about 62%. Again, evidence based and very scientifically sound. Now, why this reflects true community participation? Because community women became care providers. So when we have these community health workers, जब आप आशा की बात करते हैं या आंगनवाड़ी वर्कर की बात करते हैं, which we talk about right now, they have to become a resident of that village. You do not expect anybody who is from outside that village to become a ASHA or an Anganwadi worker or an ANM. The expectation is that people from that own community itself are going to tell us about, and having the community, the ownership of their particular health has changed things drastically over the many years. The statistics, everything shows that it has been effective since the time these ASHAs and Anganwadi workers have been introduced in the system of healthcare. They became care providers, not just recipients. Decision making, ownership and sustainability were rooted within the village. It provided that healthcare doesn't need to be hospital centric and that empowered communities saves lives. They were trained in newborn resuscitation. It is not that you always need a doctor to do a newborn resuscitation. Simple things that you detect that whether this child needs resuscitation at the first point in time, even if it is a home delivery, what is the kind of newborn resuscitation that this lady needs to be given. If that is given timely, probably that life is saved. So, the prevention and treatment of infections, preventive of maybe an umbilical infection, prevention of maybe a pneumonia, prevention of maybe cough and cold, early detection, very, very, very simple interventions for which you do not need a doctor, but that is going to save lives. So, if you have that, magnanimous this thing that you are going to save lives, lives are saved even before the intervention of doctors, and they are saved at a much larger scale with the simple interventions. Okay. So, your training is definitely essential for the people who are at the far end of that spectrum of this thing. So, your specialized care that we talk about, which has become more specialized with every passing year, the relevance is something that you might have to question at some point in time. Okay. Then identifying danger signs. A simple person who is not even a graduate, he is only a 10th pass, is only simply reading that okay, this child is having fast breathing, this child has probably pneumonia. So, let me ask this mother to give that child 2 ml of the antibiotic that I have with me. That is what she was expected to do, and that has led to prevention of that death, because that pneumonia might have, if it was not detected early, that might have recurred, that pneumonia might have progressed very rapidly to that particular, ultimately it might have led to the death. So, identifying and giving that antibiotic a single dose is something that was being trained. Even injectables are being given by these ANMs to these children, that if the pneumonia is so severe that an oral drug might not be possible, injectables such as first dose of, like immunization has been given, you give the first dose of amoxicillin to this particular baby and send that child to the hospital. Okay, it is not that everybody has to be treated in the community itself, you stop sending people to IDL. So, please do not take that idea with you. It is that you have to provide the most initial basic treatment so that the child's survival is increased till the time that child reaches the hospital. And there have been studies across, if you read that time period has been lagged, the doses have been this thing. So, with every this thing, the WHO keeps coming up with guidelines that for fast breathing this dose has been given, and maybe 10 milligram is not enough, maybe a higher dose might be given at the earlier point in time to prevent death at the hospital when the child reaches. Okay. Depending upon what microbiology, what organism is causing the kind of pneumonia. So, all of this data, all of this information comes after a lot of research and literature to ultimately implement them to prevent these deaths. Simple interventions such as warmth and exclusive breastfeeding. If the child is born low birth weight, the mother is expected, if you read about kangaroo mother care, it is a very important component that is taught in pediatrics, it is taught in community medicine. It is a simple intervention that has been taught that low birth weight babies, that is those that are born with less than 2.5 kg of birth weight, just simply putting them with their fathers and the mothers on their chest and enclosing them is going to help prevent them from dying. So, and exclusive breastfeeding is one of the components, but it is a really discouraging story that we have talked about exclusive breastfeeding, we have been taught about exclusive breastfeeding, but even after 20 years of what we have been taught, you still see people, you still see most of the population not practicing maybe exclusive breastfeeding, and children continue to die because of that, and use of antibiotics when necessary. The third component is appropriate technology. So, the first principle, second. So, third one is appropriate technology. If you read these 5, remember these 5 principles, I think that will be more than enough for this class. So, appropriate technology, Asha, you will read about that. One of the examples, another I will just to make it more interesting, is the mobile health initiative that was supports that health workers deliver timely health services. Later I will share a video because I cannot share it right now, I will share it in your group, where even not requiring a smartphone, simply by the use of SMS, maternal mortality and neonatal mortality have been saved in places such as Rwanda, where health access was not available to everybody. So, what is mHealth? It refers to use of mobile phones and other wireless technology in health service delivery, especially for communication, data collection, alerts and health education. where community health workers, the only job is ki if they notice a pregnancy, they have to send an SMS to a central server that this particular lady in this particular village is pregnant. That information has to reach. Just making that information reach to a central server so that that particular lady comes under the ambit of the health system, that if somebody is pregnant, that for the next 9 months that pregnancy has to be followed up. And there are various interventions which have been delivered through this mHealth only, that the worker, the connection is that the phone, the health worker being present with the lady, and then this information being transmitted to somebody who is a specialist, who is detecting, continuously monitoring this pregnancy and telling that okay, now you maybe need to reach the health facility, and this cannot be managed at the community. So this kind of interventions are done through mHealth, and mHealth is a very not upcoming, it has already already been as a very what should I say, accepted, and it has percolated across many dimensions of healthcare or many dimensions of diseases that we have. So it's one of the main interventions for maternal and child health only. So automated reminders for care visits and deliveries, emergency alerts sent to health facilities for quick response, and this also led to a 20% decrease in increase in facility based deliveries, and ultimately if mothers are delivering at health facilities where we have trained manpower, obviously they are less likely to die. Secondly, the fourth component is the intersectoral coordination. As we said that health is not only determined only by the health department, there are the involvement of the education, nutrition, the environment, many other departments, and that is what is intersectoral coordination and convergence is all about. Example, the Bolsa Familia program in Brazil. It's a conditional cash transfer program launched in 2003 where targets low income families and especially those with children. Cash is provided only if families meet specific conditions related to health and education. The conditions include children must attend the school regularly, the children must get routine vaccinations, the pregnant woman must attend antenatal checkups and growth monitoring, and these conditional cash transfers are across many of the health programs that we have in India, especially to maternal and child health, that is there in India also, many programs of conditional cash transfer. Conditional cash transfer means we give you money if you fulfill a certain condition. The government gives people money to fulfill a certain condition which is dependent upon them, that you come for the vaccination, you get that money, you come for this antenatal visit, so that your health outcome is improved. Now, obviously, there is a philosophy that people should not be given money to take care of their health, but it is always debatable, but ultimately people are prevented from dying. Okay, so that is something that needs to. So what this health is, it ensures vaccination, antenatal care, nutrition monitoring. Education, it tracks school attendance and learning outcomes. Social welfare manages family income data and transfers, and technology integrates databases across ministries for real time monitoring. So many of these sectors are involved when you talk about this intersectoral coordination. Coming to the last component, preventive and curative services. So you have to remember that primary health care is not only about preventive services, it is also about curative services provided at a low cost, at an efficient cost, but at the right time and at the right place. Again, human HBNC is one example, and we have the integrated preventive education. So this is across the spectrum where you have these things being given, where it is one of the largest health program. Bangladesh is one of the case study that is also cited across the global health, which you should remember, and Bangladesh has some of the better health indicators even compared to India. So even it's a small country, densely populated, maybe not as rich as India, but in terms of health indicators, Bangladesh has some of the better health indicators even when compared to India. So, and that has been largely because of the primary healthcare interventions that have been given, because of project areas where this interventions that was being given. So simple things such as breastfeeding, nutrition, family planning, support for national immunization campaigns, awareness on sanitation, hand washing and safe water, early detection, education on maternal health and cancers. Now this is largely based on infectious disease. Now you put in the component of non-communicable disease in this preventive and curative services, you will be preventing much more deaths happening due to cardiovascular disease. You prevent in change of behavior, stop smoking, stop alcohol, get a good exercise, take good nutrition, you are going to prevent a lot of death due to NCD. So that is the preventive component. And the curative component, if you talk about, this is what we keep reading again and again, so you might get a little this thing ki MCH के अलावा examples नहीं है. Screening for cancers. A simple secondary level prevention is going to prevent people from dying. Not building radiotherapy intervention units, not building big cancer hospitals, although that might be required and that is very, very costly. Cancer treatment, I have already told you, I think in previous classes, one of the costliest treatment, and it is not affordable for everywhere, even for the most richest, because it might not be treatable at the stage it is diagnosed. And secondly, even it is treatable, it is at a very, very high cost. That is how cancer kills people. It is the cancer itself, but it is the cost and the treatment, because the medical science is not that advanced enough to treat every kind of cancer. So, the only this thing is to detect it earlier, and that will come from one of the principles of secondary prevention, of early detection of the most common cancers. Fortunately, the most common cancers are the one that can be detected early. Something like prostate cancer or something like lung cancer do not show very early symptoms, and fortunately they do not kill a lot of people because they are not very common cancers. The most common cancers such as breast cancer, such as cervical cancer and oral cancer, all of these cancers can be screened early and deaths can be prevented. So that is a twist of fortunate event of events when we talk about cancer, that most of the common cancers can be detected early. So that is all I have. These 5 principles, please remember, and the video I will share with you in the, not here, but in the class, the FAP batch that you have. So if you have time, you can decide to read it, watch it, sorry. Thank you. Any questions?